Yeah, thanks so much. Just a quick note, I'd like to thank Brian and Adam. We did a special topic review for the Publications Committee, and these gentlemen were tasked with talking about cervical facet fractures and dislocations, and they actually wrote the chapter on this. I'd like to thank them for that. We're going to focus primarily on facet dislocations because of the limits of time. These are my disclosures, none of which have to do anything with the talk. Let's start with a case. This is an older gentleman who was in Asia C after a motor vehicle crash. And you can see his facet dislocations there at C6-7. You got a lot of questions. Should we use steroids in this case? Should we reduce the spine? Should we get an MRI before we reduce the spine? When should we reduce the spine? Should we get it done as soon as possible? What surgical approach should we use for stabilization? And does it matter, all this matter, based on his classification or his level of neurologic injury? Well, there's a huge variation in facet injuries. And as you can see here, sorry about the slide there, we're talking about facet fractures, and there's 10% of all cervical spine injuries. However, 75% of dislocations are facet injuries, and these can have devastating consequences, as you can see with a facet dislocation. Our treatment goals should be improvement of neurologic function to try to enhance recovery as well as we can and prevent deterioration. We should also look at skeletal realignment and stabilization, which hopefully can accelerate our rehab goals to prevent late pain and prevent late deformity. Now, there's no question on timing. We should get these done as quickly as possible. And Dr. Failings published this with Staskis now over 10 years ago, and they found a statistically significant difference in the number of AIS grade 2 improvements in patients who were operated on less than 24 hours versus those who were operated on greater than 24 hours. So we want to get to these as quickly as possible. Now, in my hands, that's closed reduction. And so as a result, we need awake cooperative patients. We need an experienced team, no evidence of head trauma or skull fracture, obviously, but it can be effective in up to 80% of unilateral and bilateral dislocations. The published complication rate in the literature in an awake, alert, cooperative patient is very low. And Jerry Grant published this from the Harborview series a long time ago now, where we reduced 82 patients in a mean of 2.4 hours, and closed reduction was successful in over 95% of them. Only one patient deteriorated 6 hours post-injury, though there were a lot of disc injuries seen on these post-reduction MRIs. Only one patient deteriorated. So this led the joint section to form a guideline that's now about 10 years old, saying that you had an 80% successful reduction rate, 1% permanent neurologic sequelae, but there was a 2 to 4% transient neurologic issue rate. There were several case reports documenting worsening, but these were only subtle case reports. And if a patient fails closed reduction, then you should go to MRI. The cases that were presented, most notably from Dr. Eismont's series, were all reduced posteriorly without an MRI. And these were reduced posteriorly, and there was worsening of a disc herniation, suggesting that if you're going to take somebody for a posterior reduction, you should get an MRI to make sure you don't have a disc herniation before you do this. What is the incidence of disc herniation? The series early papers out of Jefferson showed that there could be up to a 50% incidence of post-reduction traumatic disc herniation. And there was, Alex looked at pre-reduction and post-reduction and found that there was an increased incidence of post-reduction disc herniation, but there's actually no correlation between the presence of disc herniation and neurologic worsening in these patients. Now, this is another paper that's out of France, and what they did was they took 17 consecutive patients and actually reduced them in the MRI scanner. And what you can see here is reduction from 15 to 95 pounds. And what they found is that most of the patients had improvement in canal diameter, and none had worsening of their canal size, and none had neurologic worsening associated with these disc protrusions that you can see on the MRIs. Now, as a result, there's a recent study that's probably worthwhile reviewing in the literature from the European Spine Journal. There's a 41% incidence of traumatic disc herniations, but neurologic worsening after closed cervical traction is less than 1%. As a result, I would say that data supports closed reduction prior to MRI in the cooperative patient, and you want to stop if there's new or worsening symptoms and go to the MRI. Post-reduction MRI helps us determine the appropriate surgical approach in these patients. And so we go back to our case, and we can see how with reduction, we get a nice reduction at the C6-7 joint right there. You can see that there. And an MRI post-reduction does not show ventral compression of a disc herniation in this situation. Now, does reduction always work? This is an Olympic aerialist that we took care of who came in with this C3-4 Asia A injury and immediately was not moving. despite traction to 70 pounds over 1 hour, we could not get her reduced. Unfortunately, we couldn't get an MRI on her because the MRI scanner was blocked up, so we went and opted for ventral reduction. Now you can see the mechanism you use for ventral reduction, and you can put your pins in with the tips convergently and the ends divergently, and go ahead and put the Caspar reducer on and go ahead and reduce this patient. And that's effective in patients when you want to do an anterior reduction. In this patient, we went anterior, couldn't get them reduced still, took out the disc, went ahead and did a posterior reduction, and then we came back and did an anterior, posterior, anterior. Now, the surgical approaches, we talked briefly about anterior, posterior, and combined approaches. And John went through this pretty nicely, so we'll go through this briefly. There's a lot of evidence for an anterior approach and a lot of evidence for a posterior approach. The pros of the anterior approach have ease of positioning, less pain, it allows for reduction, but you have to be aware of over-reduction, difficulties reduction, and a cervicothoracic junction can be hard to fuse. The pros of the posterior approach is straightforward, biomechanically restores the posterior tension band, and has biomechanical superiority. There are papers that suggest that anterior can work, but you have a failure rate. This is a paper from the group in Vancouver suggesting a 13% failure rate with ACDF for facet dislocations. And the risk factors for this were facet fracture and superior end plate fracture. So our surgical options, anterior approach, if a disc herniation is present on MRI, potentially stand alone in the young neurointact patient. There's no end plate fracture, but beware of over-distraction. Posterior approach, it's a workhorse for these injuries. You can reduce people easily, you can maintain alignment, and it's robust in cord-injured patients. And a combined approach, when there's disc herniation present in a cord-injured patient, if it's irreducible and there's a herniated disc, you may require an anterior-posterior anterior, as we showed, and this allows for anterior excellent realignment and robust fusion. It may decrease the number of posterior instrumented levels as well. So in this case, we went ahead and proceeded with a posterior instrumentation, as you can see here. And in summary, closed reduction without manipulation has low risk when following a protocol. The risk-benefit ratio may be low in severe spinal cord injuries. Of course, in intact patients, you may have to use a slightly different protocol, using an MRI, then open reduction. However, there are a number of series that show you can still reduce these patients, even when they're neurologically intact, without deterioration. Thank you for your attention.